This type of program we never see in the world. This is one of the best programs. This was inaugurated by our Honorable Prime Minister of India, Narendra Modi ji. So this is the NMCN, that is National Medical College Network. On this, lot of medical colleges, entire India, they can get the knowledge. So not only limited to one medical college. So this is a beautiful program. So first greetings from Andhra Medical College. Greetings from Andhra Medical College, Vishakhapatnam and King George Hospital. So World TB Day, the topic is tuberculosis meningitis. Before you go for tuberculosis meningitis, the World TB Day, every year we celebrate on March 24th to create awareness, and the clock is tickling. The World TB Day, we will see the goals of TB under. First we attribute to Robert Koch, the one who identified the Mycobacterium tuberculosis. And he got Nobel Prize in Medicine in 1905. So tuberculosis is the most common infection in the world. 1/3 of population are infected with tuberculosis bacilli. So of all the infections, tuberculosis is most common. 1/3 of population, especially in India, infected with tuberculosis bacilli. Incidence 9 million, prevalence 11 millions, and 2 million deaths per year globally. You can see the highest prevalence rates in Asian countries, especially in India and Africa. So tuberculosis bacilli is a obligate aerobe acid-fast bacillus, the two main species which everybody knows, Mycobacterium tuberculosis and Mycobacterium bovis. Of late, they identified two more organs. Those are Mycobacterium oryzis and Mycobacterium pinnipedi, which are also, you have a lot of other mycobacteria, atypical mycobacteria, photochromogens, rapid goers, all those will not cause tuberculosis. Only these, tuberculosis, bovis, oryzis and pinnipedi causes tuberculosis. So if you see, you can see under microscope is a acid-fast bacillus. So when coming to neurotuberculosis, because the topic is tuberculosis meningitis, it comes under neurotuberculosis. 1% of all TB infections, they account for neurotuberculosis. 1% of all TB infections. Of these, the TB CNS, various forms of TB CNS accounts for 10% of all extrapulmonary tuberculosis. Pulmonary tuberculosis is very common. So 10% of all extrapulmonary tuberculosis accounts for CNS tuberculosis. What are the various forms of CNS tuberculosis? Tuberculosis meningitis, serous tuberculosis meningitis, tuberculosis of the brain, tuberculosis encephalopathy without meningitis, tuberculosis abscess, and part spine without myelopathy. There are various forms of CNS tuberculosis. So coming to TB meningitis, the TB meningitis on the rise for the last few decades. That is due to susceptibility of these people living with HIV patients to tuberculosis and increasing travel. So nowadays everybody travels, morning breakfast in Vishakhapatnam, lunch in Mumbai and dinner in Dubai. So because of increasing travel, again the incidence of tuberculosis and TBM is rise. The peak incidence occurs in children in high prevalent areas, in adults in low prevalent areas. 70% of TBM, you're talking about TBM, 70% of TBM occurs below 5 years of age. Very important for pediatrics. And 1/3 below 2 years, 40% of these people, they come with history of contact with adult tuberculosis. So that is, so primary tuberculosis, the primary site is Ghon's focus, the basic focus in the lung. That is Ghon's focus, and you have Ghon's complex, Ranke's complex, the Simmons focus, which we'll discuss for a minute in the next few slides, and the basilemia rupture into the draining lymph nodes and blood vessels. This is the Ghon's focus. The typical primary tuberculosis in a child. The parenchymal environment is more common in adults. This type of presentation, Ghon's focus, is common in children. Ranke's complex is combination of calcific lesions of the lung. You can see calcific lesions of the lung, and the lymph node is referred to as Ranke's complex. Lesions seen in the secondary TB. Full lesion, that is supraclavicular is full lesion. Osman's focus is infraclavicular. Rich focus in the subpile focus of the brain. That is rich focus in the brain. And Weger's focus in the pulmonary vein. And Simmons focus in the liver, which is various focuses. Coming to the pathogenesis, how patients develop tuberculosis meningitis. The basic focus is in the lungs. The lung, that is the Ghon's for primary focus because of droplet infection, and the bacilli through the blood it passes and reaches the meninges to the bacteremia. In the brain, in the meninges, it lodges in the subpile region as rich focus. It will be dormant for many years. When the immune is deficient, then it forms and ruptures in subarachnoid space. The rich focus, which is subpile focus, ruptures in subarachnoid space, giving rise to adhesions, vasculitis, encephalitis, adhesions at various levels, especially the base of the brain, giving rise to entrapment of the cranial nerves, presenting the sixth nerve, seventh nerve, third nerve, fourth nerve, fifth nerve, all basal features of basal meningitis, vasculitis, and encephalitis. So this is the basic pathophysiology of tuberculosis meningitis. The basic thing is rupture of rich focus, the subpile focus, present in the subpile region, giving rise to various adhesions, vasculitis, and encephalitis. So coming to clinical features, after having knowing about the bacillus and the epidemiology and various forms of teenage tuberculosis and various focus, osmos, rich, Simmons, Gones, will come to the clinical features. The triad of clinical features of meningitis anywhere, any meningitis is fever, headache, neck stiffness. It holds good for any meningitis, let it be tuberculosis meningitis, fungal meningitis, or bacterial meningitis, viral meningitis, fever, headache, neck stiffness, the basic triad of meningitis. Here, the patient typically presents with subacute course, whereas bacterial meningitis usually presents acute onset of fever, headache, vomiting, like that. Here, subacute onset from days to months, and they have prodromal symptoms lasting for 2 to 8 weeks prior to the onset of this tuberculosis meningitis, development of meningeal irritation. Those are malaise, anorexia, fatigue, fever, myalgias, and headache. The fever, unlike bacterial meningitis, here the patient will have low-grade fever. Low-grade fever, evening rise of temperature. Usually fever is seen 2/3 in children, 60 to 95% in adults. Fever can be absent. Sometimes it needs high index of suspicion. Somebody coming with a headache, a cranial nerve palsy. Even though fever is absent, one has to suspect tuberculosis meningitis. Then headache. Headache, according to International Headache Society, the type of headache, tuberculosis meningitis headache, is a secondary headache that comes under infections. That is, out of the 14 headaches, from 5 to 14, the secondary headaches, the grade is 9.1.1. So this headache, it may be acute headache, subacute headache, chronic headache. Headache can be completely absent. It is due to involvement of the meninges and inflammatory changes in the meninges. Usually holocranial headache, and it is throbbing headache, or sometimes it's so mild or totally headache can be absent. Photophobia, the fear of light, as just like other meningitis, bacterial, viral, fungal, they will have photophobia, fear of light, they fear to see the light, and once they see the light, exacerbates the pain. That is due to irritation of the basal meninges. So clinical features in various theories, if you see headache and fever most common, accounting for 50 to 95%, then vomiting 30 to 60%, photophobia 5 to 10%, and anorexia weight loss accounts 8% of patients, 60 to 80%. The signs are, these are the most common symptoms: fever, headache, neck stiffness, fever, headache, vomiting, photophobia, phonophobia, anorexia, nausea, vomiting, and weight loss. Coming to clinical signs, most important sign is the neck stiffness, which is present in off to 2/3, confusion 10 to 30%, frank comment 30 to 60%, cranial nerve palsy is most common cranial nerve, affected sixth cranial nerve 30 to 40%, followed by third nerve and sixth nerve, and they can have focal deficits. The focal deficits can be a major focal deficits or a minor focal deficits in the form of only one some cranial nerves. The major focal deficits can be hemiparesis or quadriparesis, paraparesis, seizures. Seizures are very important. It can present in 5% of the patients. Sixth nerve palsy, you can see to examine sixth nerve palsy when the patient is looking right, the right eye is not completely abducting. So usually sixth nerve palsy is one of the important, especially in children. So they have headache or mild fever with sixth nerve palsy, and without fever, without headache, only sixth nerve palsy in a child, unless otherwise proved it is spontaneous glioma. In a child with sixth nerve palsy, unless otherwise proved, without fever, headache, vomiting, it is spontaneous glioma. Somebody has fever, headache with sixth nerve palsy, most of the times when the duration is more than 6 days, the most commonly it is tuberculosis meningitis. So see for sixth nerve palsy, then third nerve palsy, other common things. They can only present headache and sixth nerve palsy, headache and third nerve palsy, fever, headache, sixth nerve palsy, fever, headache, third nerve palsy. So you can see the third nerve palsy, the all 3 Ds. That is drooping of the lid, dilated pupil, and divergent squint. You can see here, patient difficult to elevate the right eyeball, and you have seen the ptosis. In the pupil also you can see that is dilated, drooping, and divergent squint. The third nerve palsy can be presenting feature of tuberculosis meningitis. So also seventh nerve palsy. We have seen few patients presenting with just like Bell's palsy. One of the medicine assistant professor here working now, he came to us with Bell's palsy like picture, seventh nerve palsy. We thought it is Bell's palsy, treated. After a few weeks, he came with fever, headache, then did LP suggested tuberculosis meningitis. So they can only present with just LM and facial palsy with a plus or minus headache, fever. So should have a high index of suspicion. Or especially tuberculosis meningitis, we have seen for the last 20 years presenting varied presentation. The classic presentation, definitely classic presentation is classic fever, headache, vomiting, neck stiffness. But TBM, we have seen presenting only with cranial palsy, only fever, low-grade fever lasting for more than 7 days, only headache, only cranial palsy, presenting as stroke, presenting as neurocognitive impairment, presenting as seizures. So all the time, tuberculosis meningitis is very common. One should have some knowledge about tuberculosis meningitis. The blindness, other important feature of tuberculosis meningitis. The causes of blindness in a patient of tuberculosis meningitis are optic-chiasmal arachnoiditis, optic atrophy. You can see the third ventricle compressing the optic chiasma and the optic nerve tuberculosis, and erythropoietic toxicity. There are various causes of blindness in a patient. You can see the diffuse thickening. Here you can see the homogeneous enhancement, the ring enhancement. You can see this. And you can see necrotic lesion. You can see the necrotic lesion and reduction size after treatment. You can see. So these are various. The third nerve tuberculoma can present with blindness, and sometimes the occipital infarct. The presentation is occipital infarct. To start with, the tuberculomas, erythropoietic toxicity, optic-chiasmal arachnoiditis, occipital infarcts, especially bilateral. All these causes blindness. The patient can also present with hemiplegia. We see good number of patients presenting hemiplegia with fever, mild fever, headache. Usually a headache, fever, hemiparesis, always suspect tuberculosis meningitis. They can have paraparesis due to part spine or craniospinal meningitis. And seizures, various tonic GTCS or symptomatic seizures, it can be presenting feature of tuberculosis meningitis. So cranial palsies may be the presenting feature of tuberculosis meningitis. Cyst nerve is the most common. Others are third, second, seventh cranial nerves. Visual loss is due to involvement of optic nerve. OCA, optic-chiasmal arachnoiditis. Third ventricular compression of the optic nerve is hydrocephalus, optic nerve glioma, erythropoietic toxicity, and occipital infarcts. So hemiplegia, quadriplegia, secondary to bilateral infarct, a secondary raised ICP. Abnormal movements may dominate in a child. Child presenting with any involuntary movements always suspect tuberculosis meningitis. Say patient child has fever, headache with a choretic lesions. Semi-purposive, abrupt, brief, rapid, jerky, involuntary, irregular, semi-purposive distal movements. They get a movement like this, they don't know what to do. So any child presenting with a sudden onset of chorea or chorioarthrosis, hemiparesis, especially fever, headache, suspect tuberculosis meningitis, abnormal movements, seizures, and the disease, the progress to apathy, irritability. In children, altered mental status is more common presentation. They can present with altered mental status. Headache is not very common in children, and vomitings are frequently present. Elderly in developed world, atypical presentation is very common. Signs of meningitis are absent. Like most common, most sensitive sign of meningitis is neck stiffness. The neck stiffness can be totally absent. Neck stiffness can be present only terminal neck stiffness. Neck stiffness can be shifting neck stiffness or fluctuating neck stiffness. When he examines, he finds neck stiffness. Someone examines, they may not find neck stiffness. So neck stiffness can be intermittent, terminal, fluctuating, mild, or gross, or totally absent. That's why you should have high index of suspicion. And seizure findings may be atypical. Seizures are more common in children. So this is very, very important slide. So diagnostic criteria for classification of definitive, probable, possible, and not tuberculosis meningitis. The Marius has given this criteria. The clinical criteria, symptoms duration more than 5 days. It scores 4 marks. Somebody comes with fever, headache, vomiting, altered sensorium, more than 5 days, suspect tuberculosis meningitis. Systemic symptoms like weight loss, night sweats, persistent cough for more than 2 weeks. So when you give history of a TBM patient, any meningitis, they have fever, weight loss, night sweats, persistent cough for more than 2 weeks, very, very important. So give 2 marks. History of recent close contact with the individual primary pulmonary tuberculosis. Then you give 2 marks. Focal deficits 1, cranial palsy 1, altered consciousness 1. This is clinical points. Whereas CSF, clear appearance 1, cell count 10 to 500 1, lymphocyte predominant, all you know. In CSF, you get cells between 10 and 500 with lymphocyte predominance and protein concentration usually more than 45 milligrams. CSF plasma to glucose ratio less than 50%. That is CSF criteria. The cerebral imaging criteria very, very important. Once you see a scan without seeing the patient, somebody sees your scan. The important point here, the pre-contrast enhancement, the basal hyperdensity in a CT scan. Once you see a CT scan, in plain CT scan, the pre-contrast basal hyperdensity, very, very important point, suggests for tuberculosis meningitis. So also if you find hydrocephalus or basal meningeal enhancement, you have various systems, the basal systems, periaqueductal systems, preponderant systems, podogeminal systems, and the systems that are enhanced in contrast CT scan. Again a point, tuberculoma is there. Again it suggests of TBM with tuberculoma. Infarcts are there. Somebody comes with fever, headache, vomiting, you have seen infarcts, again suggests for tuberculosis meningitis. Common with tuberculosis meningitis. So as I told you, pre-contrast basal hyperdensity is a very, very important point. And evidence of tuberculosis elsewhere, in investigations again gives 2 marks. And chest radiograph suggestive of tuberculosis, signs of tuberculosis, miliary tuberculosis, 50% you get signs of tuberculosis in the chest X-ray that you can see in the investigations. So AFB 4 marks, positive not from extraneural specimen, again 4 marks. So this is the Maria's grading. A word about tuberculosis serous meningitis. Signs of meningeal involvement, especially in children. Normal CSF or mild increase in cell and protein content. Unlike the classic TBM where you get the cell count 50 to hundreds, 500, here you get mild increase in CSF cell count maybe 15, 20, 25 with a mild protein rise. The pathogenesis here is the oxidative reaction in the meninges around the tuberculosis focus. The intracranial complication of tuberculosis otitis media can present as tuberculosis serous meningitis. Initial formation of intrafocus during hematogenous spread from a primary complex from the lung. Then prognosis is good in tuberculosis serous meningitis. Tuberculosis encephalopathy. Tuberculosis encephalopathy described by Udani and Dastur in India in children with pulmonary tuberculosis. The diffuse cerebral disorder, convulsions, stuporose, comatose, obtundation, and without signs of meningeal irritation. They don't have any neck stiffness, Kennick sign, Mudjiski scan, no. Meningeal signs are absent. CSF is largely normal, almost always normal, or slight increase in protein and cell count. Then coming to intracranial tuberculomas, the very, very common, which we see very frequently presenting as seizures. Somebody present with seizures, always with a spacer, with a ring enhancing lesion, always suspect is a cysticercosis or tuberculoma in the brain. You know the difference between cysticercosis and tuberculoma? Tuberculosis are more than 20 millimeters in diameter with significant perilesional edema and midline shift. Whereas cysticercosis, the neurocysticercosis, solitary ring enhancing cysticercosis, less than 20 millimeters in diameter, without significant edema or mild edema, without focal deficit, both can present as a single seizure. Presenting as a seizure, not single seizure, they present as a seizure. Vedantam Rashekar from CMC Vellore has given a criteria for cysticercosis, the neurocystic granuloma. Cysticercosis granuloma, that is size less than 20 millimeters, presenting clinically as seizure, without disproportionate edema, mild edema, without midline shift, goes in favor of cysticercosis. Tuberculoma more than 20 millimeters with a moderate to severe edema and a midline shift. So the symptoms related to the location, where they are located, is it brainstem, frontal, temporal, parietal, thalamic. The symptoms related to that with low-grade fever, headache, vomiting, and supratental tuberculomas usually present seizures and focal deficits and papilledema. Infratental tuberculosis are more common in children. They present with brainstem syndrome, various brainstem syndrome like bulbar palsy, ataxia, and multiple cranial palsies. The child presenting with multiple cranial palsies, ataxia, bulbar palsy, think the list may be in multiple tuberculomas as well as tuberculosis meningitis. So intracranial tuberculosis sepsis, as we told, TBM is most common. They can have tuberculosis encephalitis, tuberculosis serous meningitis, and tuberculomas and tuberculosis sepsis. 4 to 7.5% of patients with senior tuberculosis, they have tuberculosis sepsis. You can see in subsequent slides some tuberculosis sepsis images. Usually solitary, they are larger, progress much more rapidly than tuberculomas. And partial stages Their focal deficits anywhere abscess, characterized by fever, headache, and progressive neurological deficits. Here also patient will have fever, headache, and a progressive deficits like hemiplegia or canal palsy and symptoms and signs of rise CT. So clinical staging. After clinical features, we'll go for clinical staging. You have two stages. One is the clinical staging. The stage 1 is stage 1 early, stage 2 intermediate, stage 3 late. Early, late, in between you have intermediate. You're not too early, not too late. Okay, early, late, in between you have intermediate. Early stage, often it is missed. The diagnosis is missed because non-specific symptoms and signs. All symptoms, the prodrome symptoms, is malaise, mild fever, anorexia, nausea, night sweats. So you may not think it is tuberculosis meningitis. Every chance of missing the stage 1, the prodrome stage, 2 to 4 weeks. No neurological deficits. Patient is completely conscious. GCS 15/15. Come to stage 2, the intermediate stage of meningeal irritation. Here the bacilla invades. You have seen the pathogenesis. Start from the Goens focus up to Rich focus. The tuberculosis bacilla invade the meninges, giving rise to meningeal signs like neck stiffness. Most important, most sensitive sign of meningitis is neck stiffness. Your Kennick's, Budzinski's, Edelman's grade 2, and Bickley's sign. All signs can be present. Most important being neck stiffness and minor deficits. Minor cranial deficits, single cranial, sixth nerve palsy, seventh nerve palsy, third nerve palsy, not like hemiplegia, quadriplegia, decipitated, decorticate, these major deficits. They can present minor deficits, minor neurological deficits with a behavioral change, lethargy, meningeal signs, that is stage 2 or intermediate stage. This stage 2 accounts for 60% of TBM. So usually we diagnose patients in stage 2. Somebody come with a behavioral change, cranial palsies, definitely don't leave. We'll investigate, we'll take scan, we'll do LP, then we'll get the diagnosis. Most of the TBM which we see are stage 2. Accounts for 60%, stage 1 often misdiagnosed, that accounts for 20%. Once you even miss in second stage, because patient diabetic, you think diabetic third nerve palsy, you will miss the diagnosis. You don't do LP, don't do, if you do MRI, MRI normal. It needs high index suspicion. You're a diabetic patient, you may write it's third nerve palsy, diabetic, or you have to think, why can't it be a tuberculosis meningitis? Stage 3 late, then stupor, comatose, unerosible, unresponsive state, the comatose state, abnormal movements, etherosis, hemibalismus, chorea, tremors, seizures, severe deficits like hemiparesis, quadriparesis, multiple canal palsies, not a single canal palsy, multiple canal palsies, all these can present in the stage 3. Coming to BMC staging, that is Modified United Kingdom Medical Disease Council grading of TBM. This grades depends on the GCS, Glasgow Coma Scale. You have eye opening, verbal response, and motor response. Eye opening, spontaneous speech, pain, none. Verbal response, well orientation, confusion, inappropriate, incomprehensive, none. Motor response is obeys commands, localized pain, withdrawal to pain, flexion to pain, extension to pain. Very important when you give stimulus, painful stimulus, supraorbital region, nail bed, sternum, the patient extends. That carries poor prognosis. Simple thing. You apply pressure to these places, supraorbital, nail bed, or sternum, patient extends his limbs, carries poor prognosis. GCS maximum score is 15, minimum is 3. GCS fully conscious, GCS 15/15, no focal deficits, that is grade 1. Patient is conscious, coherent, alert, no focal deficit, but still there is a case of TBM, that is grade 1 TBM. Grade 2 is fully conscious with focal deficits, with reduced consciousness or reduced consciousness reflected by GCS 10/14 with or without focal deficit. When the GCS is 10/14 with or without focal deficit, that is grade 2. Grade 3 is comatose patients with GCS less than 10 with or without focal. Patient is comatose with GCS less than 10 with or without focal deficits, that is grade 3. The grade 3 carries 50% mortality. You may ask why bother about all these grade 1, grade 2, grade 3. The grade 3, suppose patient is conscious, coherent, a simple headache and a seizure, to diagnosis TBM with a seizure. Otherwise, patient is normal. Patient came to your OP with walking. To diagnosis TBM after 2 days, patient has seizure. That is 50% mortality. You have to explain the attenders. Once patient has seizure, it comes under grade 3, carries 50% mortality. So other presentation of TBM, you've seen the classic presentation, fever, headache, vomiting, meningitis like presentation, acute, subacute to chronic presentation is common, very common, over a period of days to months. But TBM patients can occur acutely. This is very, very important. Nowadays, we rarely see acute meningitis. Hardly once in 6 months like that we see. But tuberculosis meningitis, every week will not pass without seeing a patient of tuberculosis meningitis. These patients, they can present acutely and mimics like acute bacterial meningitis. And they can present only with seizures, allergic tuberculosis encephalopathy. I told you already, only cranial nerve palsy, sixth nerve palsy, third nerve palsy, with a blindness at a seventh nerve palsy. They can only present single cranial nerve palsy, multiple cranial nerve palsy. They can present a stroke like a hemiparesis. They can only present with raised ICT, like headache, vomiting, altered sensorium, or so presentation of papilledema, raised ICP, tuberculosis serous meningitis we have discussed already, and neurocognitive impairment. Nowadays we see patients, TBM patients, subacute to chronic, presenting as neurocognitive impairment, major neurocognitive impairment or minor neurocognitive impairment. So signs of meningeal irritation. In subsequent slides you can see how to elicit neck stiffness. For the time being, the neck stiffness, most important, most specific sign of meningitis is neck stiffness. Next you have Kennig's sign, Budzinski's neck sign, leg sign, symphysis sign. You can see here. So meningeal sign, neck stiffness, unable to touch the sternum with the chin. You can see subsequent slides. The Kennig's sign, Budzinski's sign, and Letzig's sign. Why are you not playing? Not playing. Okay. There is the neck stiffness. You keep all your 8 fingers over the occiput. Remove the pillows, something is there behind the neck, and try to flex the neck. You find resistance to flexion of the neck. So coming to complications. What are the complications of tuberculosis meningitis? Important complication, you diagnose TBM, started treatment, you discharge the patient. Again, they come with various other important features. The progressive hydrocephalus that can only present with a headache, increasingly severe headache, worsening of the headache, or vomitings. I told you already blindness, various causes of blindness, up to arachnoiditis, up to bilateral occipital infarcts, or tuberculosis, or compression by third ventricle, hyponatremia, maybe due to cerebral salt wasting, or SIADH, or vasculitis presenting as strokes, arachnoiditis presenting as quadriparesis, paraparesis, various weakness, paradoxical reaction that we'll discuss, and treatment-induced complications. Communicating hydrocephalus, most common complication of TBM is caused by blockage of basal systems by inflammatory exudates. The inflammatory exudates present in the base of the brain. This causes blockage of the pathways, basal systems, leading to communicating hydrocephalus. They can also present non-communicating hydrocephalus because of obstruction due to tuberculoma, rarely tuberculous sepsis. Ischemic infarcts are very common, 20 to 40% of cases, mostly with basal ganglia and internal capsule, resulting from vascular compression of occlusion of small perforating vessels, particularly lenticular-straight vessels, or thalamoperforate arteries, giving rise to necrotizing arteritis. You can see the hydrocephalus as TBM, the GAD enhanced. The Pallur grading system for shunt in a TBM for neurosurgeons, grade 1, grade 2, grade 3, grade 4, Glasgow Coma Scale 15, no neurological deficit, normal sensorium. So this is not necessary for undergraduate student. The spinal tuberculosis arachnoiditis. Tuberculosis lesion primarily arising from spinal meninges, just like the brain meninges. The tuberculosis lesions can spread to spine, affecting the meninges, giving rise to tuberculosis spinal arachnoiditis, downward extension of intracranial tuberculosis meningitis, and extension of tuberculosis spondylitis or discitis. So what are the predictive features for tuberculosis meningitis? In children, prodrome more than 7 days. Already we have discussed that point. Focal neurological deficit, they find hemiparesis, cranial nerve palsies with optic atrophy, especially in children presenting the abnormal movement, chorea, tremors, erythrosis, hemibalismus, and more than 50% lymphocytes in CSF, the predictive factors of TBM versus non-TBM. Other predictors are more frequent cranial nerve palsies. We have seen number of times, third nerve, fourth nerve, sixth nerve, seventh nerve, the decerebrate posturing, and hydrocephalus, the pre-contrast, the basal enhancement, very important feature in CT scan. When you take CT scan, we find the peak contrast enhancement, very important predictor of tuberculosis meningitis. And in a suspected TBM, we find tuberculomas, again very important predictor for TBM, and infarcts. When you are suspecting meningitis, you are finding infarcts, is likely to be tuberculosis meningitis. But decerebrate rigidity and decorticate rigidity. Decerebrate and decorticate. Decerebrate rigidity means the lesion is in between two colliculus, superior colliculus and inferior colliculus. The patient like this. This is decerebrate. Decorticate, the patient flexes both upper limbs and extensively both lower limbs. Both again carries poor prognosis. Other different diagnosis, partially treated bacterial meningitis. Though bacterial meningitis is rare, always in a TBM suspect and patient not responding, partially treated bacterial meningitis and other meningitis, syphilis, neurosyphilis, meningovascular syphilis, very important. Indeed, nowadays we are seeing more number of neurosyphilis, especially meningovascular syphilis and neurobrucellosis, fungal infections, amoeba, especially primary amoebic meningoencephalitis caused by Naegleria and Hortonella, and toxoplasma encephalitis, subacute chronic granulomatous response, CNS sarcoidosis, lupus, and Behçet's, CNS lymphomas, and castomatous meningitis. All these are DD for tuberculosis meningitis. So CNS tuberculosis, a word about CNS tuberculosis in AIDS features. CNS involvement, 10 to 20% of AIDS-related tuberculosis, high mortality rate, increased risk of tuberculosis meningitis. The one who has PLWH with tuberculosis, increased incidence of tuberculosis meningitis. Granulomas are less common than meningitis. This is an important point. Intravenous drug abuse is at higher risk, does not appear to alter the clinical course or response to therapy and prognosis. Infection with atypical mycobacteria is common here. That is photochromosomes, and rapid goers. HIV and TBM, the meningeal enhancement, hydrocephalus and imaging, less common. And there could be more bacilli in the meninges. Those with TBM and HIV often have concomitant extrameningeal disease. Tuberculosis abscess are more common in HIV than non-HIV infected patients. So exposure to, how will diagnose tuberculosis meningitis? Exposure to active disease, that's pulmonary tuberculosis. Somebody is coughing, hemoptysis, weight loss, pulmonary tuberculosis, on treatment with ATT, the patient is exposed to a patient of pulmonary tuberculosis. So you think the possibility of tuberculosis meningitis, immunosuppressive state, like a chronic non-diabetic and uncontrolled diabetes, or chronic kidney disease, chronic renal disease, cirrhosis of liver, HIV, any on steroids, tuberculosis elsewhere in the body, like lymphadenopathy, or sinuses, scars, non-healing ulcers, and pulmonary TB and chest X-ray, the Gomes focus, or fundus, choroidal tuberculosis, very important, and Monteau test. So tuberculosis elsewhere in the body, it's immunocompromised individual, positive family history of prior contact with tuberculosis, 50% children more common, this is more common, contact with adult with primary tuberculosis, and alcoholics. You have to take the history. In general examination, see for lymphadenopathy, in all patients of TBM, lymphadenopathy, spinal lesions, bony lesions, discharging sinuses, non-healing vaginal ulcers, scrotal mass, in chest X-ray for miliary tuberculosis, hilar lymphadenopathy, lung infiltrates, tuberculin skin test. The key to diagnosis is CSF analysis. So chest X-ray, 50% you will find picture like this. 50% you can see pulmonary tuberculosis. All the patients we suspect in tuberculosis meningitis, all the time you have to see for pulmonary tuberculosis. You just take the chest X-ray. Choroidal tuberculosis, always refer to ophthalmologist, the yellow lesions with indistinct borders, singly or in clusters. Very important. Choroidal tuberculosis are very important features you can see with ophthalmoscope. More frequent as a TBM with miliary tuberculosis. And they're visually pathognomic of tuberculosis etiology. Once you see these yellow lesions, that's for choroidal tuberculosis, that is pathognomic of tuberculosis etiology. Tuberculin skin test. Tuberculin skin test again first described by Robert Cox, of that known as Monteau's test. Everybody know Monteau test. Monteau's Mandel test, Pirqui test, purified protein derivative test, or tuberculosis screening test, Monteau screening test with various names. The good screening test, Monteau is positive in 50% of the patients. So in HIV patient, more than 5 millimeters HIV positive patients, here you have to see the induration, not the erythema. The very important point when you do a tuberculosis purified protein derivative test. When you do Monteau's test, intradermal test, when you inject 0.1 to 0.1 ml of this purified protein derivative, C for not for erythema, C for induration. In the induration more than 5 millimeters HIV positive patient, a recent contact with active TB or organ transplant. More than 10 millimeters in case of recent arrivals from high prevalent countries or IV drug abusers, children less than 4 years. More than 15 millimeters, person with no known risk factor for TB. So when you do routinely for all of you, so when you do Monteau's test, when you say positive, when the induration is more than 15 millimeters. So this is, you don't measure the erythema, measure the induration. So next is very important investigation is CSF analysis. When you suspect tuberculosis meningitis, always do the lumbar puncture. Lumbar puncture, take the CSF and see it, CSF normal pressure or opening pressure when you are doing the CSF pressure. Star color, cobweb coagulum, elevated CSF protein, normal CSF protein is 15 to 45 milligram per deciliter, and the protein elevated more than 50, 100, 150, 500. Elevated low glucose, not like bacterial meningitis where the glucose is less than 20, here glucose may be 40, 50 like that. Pleocytosis with lymphocyte predominance, very important to distinguish tuberculosis meningitis versus bacterial meningitis. The point here is early stages, TBM patients can have polymorph predominance. So simple presence of polymorphs will not exclude diagnosis of tuberculosis meningitis. You have to see each thing, not only simple CSF contains 5 polymorphs or 2 lymphocytes is not a case of tuberculosis meningitis. See everything, see correct tuberculosis, see chest X-ray, see Montos, see the clinical features, see the CT scan, see the pre-contrast hypodensity. So then come to a conclusion, especially when you are in doubt, because it is more common meningitis than other meningitis. The macroscopic appearance, you can see the cobweb formation. When you allow it to stand for a day, you can see the cobweb formation. You can see the cobweb tuberculosis meningitis, one of our patients of CSF. So yellow, just to have some knowledge, yellow blood breakdown products, hyperbilirubinemia, CSF is yellow, nothing to do with TBM. Orange, blood breakdown products, high carotenoid ingestion. Pink, again blood breakdown products. Green, hyperbilirubinemia or purulent CSF. Brown, meningeal melanomatosis. So CSF analysis, normal CSF cell count, so 0 to 5, cell count is 100 to 500. Lymphocytes usually 75%. Protein 15 to 45. It may range from 50 to 100, 100 to 200, 200 to 500, usually 100 to 500. Glucose decrease usually less than 45 milligrams. In bacterial meningitis, less than 20, less than 10. Low chloride levels because of recurrent vomiting. Piece of glucose protein ratio is 0.5. So bacteriological diagnosis, demonstration of AFB. So this is a gold standard. Demonstration of acid fast bacillus. Very few slides you have seen the acid fast bacillus, how it looks like. So the gold standard, 100% specific on Gill-Nielsen staining. So culture by LJ media. That is Lowenstein-Jensen medium. We'll see what are the constituents in LJ media. Sensitivity is 15 to 70%. It takes 8 to 12 weeks. You should not wait to treat for 8 to 12 weeks, but it is again a good automated systems, radiometric liquid medium, Bactec 460 and sensitive of culture 10 to 100 AFB per ml for CSF. LJ media constituents, mineral salt solution 600 ml, malachite green which inhibits other growth of other organisms 20 ml, beaten egg again 1000 ml, 20 to 22 eggs, mix the above, then distribute in McCartney bottles used to cultivate mycobacteria by LJ medium. So this is the LJ medium. Minimum 6 ml needed to adults, 3 ml children. So this is very important. Expert MTB or resistance to rifampicin, RIF. It is a cartridge-based nucleic acid amplification test. The expert MTB. Automated diagnostic test that detect Mycobacterium tuberculosis DNA and resistance to rifampicin. So expert MTB is very, very important, which is automated diagnostic test, detect Mycobacterium tuberculosis DNA and resistance to rifampicin by nucleic acid amplification test. Sensitivity is 56%, specificity is 98%. Rifampicin resistance can be diagnosed, can confirm CNS tuberculosis. So WHO 2011, expert MTB and rifampicin, resistance to rifampicin should be used as the initial diagnostic test in individuals suspected with multi-drug resistant tuberculosis or HIV-associated tuberculosis. So CBNet, the suspect criteria, all patients, people living with HIV, all MDR close contacts, you have to do the CBNet. All retreatments mean negative cases, all extrapulmonary cases, all pediatric TB suspected cases, and referral cases from public-private partnership, the CBNet should be done. The CBNet, better than sputum microscopy. What is the advantage of CBNet? Better than sputum microscopy. CBNet tell about rifampicin resistance quickly. CBNet also recommended the first line modality for diagnosis of tuberculosis meningitis in HIV patients. So CBNet is very important. CSF PCR. Sensitivity is 80 through 1/3 to 90. Specificity is 88 to 100. Multiplex PCR using ISR 110 and MPB 14B by Sharma et al. You can do this. A-B staining, demonstration of acid-fast bacillus in CSF smears, a gold standard for diagnosis of tuberculosis, but it takes time. So neuroimaging. So after having LP, CSF analysis, so neuroimaging, very important is CT and MRI. Sometimes CT gives important clues. That's what we are discussing in the beginning. That is pre-contrast basal enhancement, intense thickening and enhancement of meninges. Once the thickening of meninges is there, enhanced contrast, enhancement of meninges, basal exudates, the prepontine and aqueductal cisterns, prepontine cisterns, all these cisterns, when the basal cisterns, basal exudates, hydrocephalus, they're common in TBM patients. Infarcts, what we see in CT, infarcts, hydrocephalus, thickening and enhancement of meninges, edema, tuberculoma, tuberculosis sepsis, all we can see in case of with CT or MRI. You can see the intense enhancement of the meninges, hydrocephalus with TBM, the GAD enhancement. You can see tuberculomas, you can see tuberculous. Here you can see tuberculosis sepsis, very big. So lumbar puncture, all patients, lymphocytic pleocytosis with low serum CSF glucose ratio, very important. HIV testing, all patients, every patient suspected TBM, you have to take lumbar puncture after CT or MRI. HIV testing is a must. Chest X is a must when you are in rounds. When you are suspecting TBM, HIV report should be there. CT or MRI should be there. LP should be there. Chest X should be there. Very simple, all available in KGH, all government hospitals. Chest X you can easily do. After doing CT, MRI, if no contraindication, you can do LP. HIV you can do very easily. So all basic tests in the patient suspected TBM. So the LP, HIV testing, chest X-ray, CT brain, MRI brain, in selected cases where diagnostic uncertainty. So end TB strategy, a world free of TB, zero deaths, disease and suffering due to TB. The end TB strategy by target by 2030, 2035, reduction in number of TB deaths by 90% by 2030. So we after knowing about TBM, we should diagnose TBM, we should not miss TBM. We try to diagnose TBM in the stage 1 or we have to prevent TBM. Okay, so after having the knowledge, so we have to prevent reduction of the number of TB deaths by 90% by 2030, 95 by 2035, maybe 100% by 2040. Reduction TB incidence rates, 80%, 90%. TB affected families facing catastrophic cost due to TB. That's why government is doing a lot of things. So it should be 0-0. They should not feel any. They should not pay any. So most of all the drugs, they are free of cost. So TB affected families facing catastrophic cost should be 0 by 2030 and 35. They should not pay anything. For treatment, final aspect is treatment. The treatment is the 4 conventional drugs. Those are isoniazid, rifampicin, pyrazinamide, and ethambutol. The 5 milligrams, 50 milligrams, very easy. 5, 15, 25, and 15. Ethambutol is 15. Various regimens are there. First, you have to give all 4 drugs for 2 months. INH, rifampicin, pyrazinamide, and ethambutol for 2 months. Remaining 10 months, you have to give only 2 drugs. That is rifampicin and INH. That is the basic treatment. For pulmonary tuberculosis, we give all 4 drugs for 2 months. All other 4 drugs for 2 drugs for 4 months. For tuberculosis, meningitis, or senior tuberculosis, give treatment for at least 1 year. What we are doing. The first 2 months, all 4 drugs. Next 10 months, only INH and rifampicin. UK guidelines 12 months, CDC 9 to 12 months, South Africa 6 months. The guidelines varies. The DOTS, now we are not using DOTS. Direct object treatment strategies, you can skip it. Drug resistant tuberculosis, very, very important. Nowadays, we are taking a lot of patients of drug resistant tuberculosis. Multi-drug resistant tuberculosis, resistance to, at the definition of MDR is resistance to at least INH and rifampicin. That is MDR tuberculosis. XDR means extreme drug resistance. Extreme drug resistance means resistance to at least INH, rifampicin, and any fluoroquinolines, at least 1 injectable drugs. This is XDR. You have MDR, XDR, and rifampicin resistance. The resistant various forms you see, whether only rifampicin resistance, INH resistance, and multi-drug resistance, extreme drug resistance, both INH and rifampicin resistance. The various resistance you will find. So some guidelines, WHO 2017 guidelines, 6 months rifampicin-based regimens for pulmonary tuberculosis, fixed dose combination over separate drugs. Some people write rifampicin, INH, pyrizinamide separately. The preferred is fixed dose combination. You have AKT4 or 4-COX, which is fixed dose combination. Daily dosing remains the recommended dose frequency. Some people give dots, alternate. No, you give daily. TB treatment should be initiated first, followed by ART. When patient is PLW, HIV, people living with HIV, with tuberculosis, first TB treatment should be started, initiated first, followed by ART as soon as possible within the first 2 months, first 8 weeks of treatment. CD4 count less than 50, they should receive ART within 2 weeks. This is important point. See the CD4 count is less than 50, start ART as early as you can within 2 weeks. So those are the highlights points. Tuberculosis meningitis, an initial adjuvant, corticosteroid therapy with dexamethasone or prednisolone, they have to start and taper over a period of 1 to 2 months. 6 to 8 weeks should be used. And drug susceptible testing should be conducted. Already we have discussed. And video observed treatment may replace DOT, and decentralized mode of care is recommended. So standard treatments we have already discussed. The 4 drugs for 2 months, INH rifampicin for 10 months. So drug resistant tuberculosis, this is very, very important. Essay question for DM neurology postgraduates. So MDR TB is resistance to both INH and rifampicin. Extreme or extensive drug resistance is resistance to both INH, rifampicin, and plus 1 fluoroquinolones and 1 injectable drug. This is XDR, definition of XDR. So shorter MD TB course, intensive phase, continuation phase is not much necessary. So this is very important. Longer MDR treatment regimens, treatment for RR TB and MDR TB at least 18 months. When you suspect multi-drug resistance, the treatment should be 18 months. The first point, unlike 6 months to 1 year, it is 1.5 years. Unlike pulmonary tuberculosis, it was 6 months. TB, CNS tuberculosis for 1 year. Multi-drug resistant tuberculosis treat for 1.5 years. At least 5 effective drugs. Second point, 5 effective drugs. In TB, you give 4 drugs for 2 months, 2 drugs for 10 months. In drug resistant tuberculosis, give 5 effective drugs. At least for 18 months, is the intensive phase recommended. Pyrizinamide is a must. This is very, very important. Of the 5 drugs, you should know what are the 5 drugs. I am telling you, 5 drugs are a must. What are the 5 drugs? Pyrizinamide is a must. And 4 core second line TB medicines. We have to know what are the other line drugs, other groups of drugs you have to use. Group A, Group B, Group C, Group D are there. Of these, Group A, B, you have to take 1 drug from Group A, 1 drug from Group B, at least 2 drugs from Group C. This is very important. 1 from A, 1 from B, 2 from Group C, apart from pyrizinamide. So this is the important treatment of multi-drug resistant tuberculosis. Pyrizinamide is a core feature. Apart from this, you have to another 4 drugs. 1 from Group A, 1 from Group B, other 2 from Group C. So we'll see what are these groups, Group A, B, C, D. Group A is fluoroquinolones. So apart from pyrizinamide, take 1 drug. What drug you will take? Levofloxacin, moxifloxacin, latifloxacin. 10-15 years back, we used to use moxifloxacin. Now we are using levofloxacin. Use levofloxacin. The Group B drug, is it amikacin, capramycin, kanamycin, streptomycin? You can use either amikacin or streptomycin according to other comorbidities. So 1 drug from injectable drug, 1 from Group A, levofloxacin, 1 from Group B, that is streptomycin or amikacin. Usually use streptomycin. Patient is deaf, you should be very careful. Other second Group C, this is very important. Others, Group D, I already told you, pyrizinamide is a must. Group D, 1 is pyrizinamide, that is a must. Apart from pyrizinamide, you have to select 4 drugs. 1 from A, okay, levofloxacin. 1 from B, okay, amikacin or streptomycin. 3 are over. You have to choose 2 more drugs from Group C. What drug you see from Group 3, Group C, ethionamide, prothionamide, cycloserine, linezolid, and clofazimine. So we use ethionamide and cycloserine or linezolid from Group C. Frequently use these 2 drugs, easily available outside. Ethionamide, cycloserine, linezolid, clofazimine, all available. The point is, you have to make 5 drugs, 1 pyrizinamide, which is used in AKT4 or 4-COX. Apart from that, 1 Group A, 1 Group B, do Group C. One more point you see, in the minimum number of effective TB medicines cannot be composed as given above. I am telling you pyrazinamide, 1 from A, 1 from B, 2 from C. When you cannot take 2 drugs from group C, or you cannot take 1 drug from group A, group B due to various reasons, then you can utilize these group 2, D2, D3. Those are very important drugs, very costly drugs. Government of India giving free of cost. That is bedaquiline and delaminid. You should know more about. We will just briefly discuss. Duration intensive phase 8 months, continuous phase. Intensive phase 8 months, unlike 2 months here. 8 months intensive phase and continuous phase is 12 months. So a few words of bedaquiline, make short notes. Is a diaryl quinolines, mechanism of action inhibition of mycobacterial ATP synthase proton pump. Elimination of life is more than 14 days. Dose is 400 mg per day for the first 2 weeks, then 200 mg TID for 3 to 24 weeks. The most frequent adverse effect is nausea, arthralgia. This is a black box warning FDA drug, a very costly drug. Delaminid. Next is, this is bedaquiline. Next is delaminid. It is a nitroimidazole class. Mechanism of action blocks since the mycolic acid and release nitric acid, which is bactericidal. Half-life is 36 hours. Recommended dose is 100 mg twice a day for 24 weeks. Delaminid indication, MDR, rifampicin resistant tuberculosis or chloroquine resistant tuberculosis. As I told you, when you cannot take a drug from group A, group B, group C, then you can add delaminid or bedaquiline. Treatment of TB and HIV patients, issues, drug interactions, drug toxicity, paradoxical, immune reconstruction syndrome, and duration of treatment or choice. There are various things you have to keep in mind. The lack of time, we are skipping all these things. Immune reconstitutive inflammatory syndrome, IRIS, one of the important complications. 2 forms, one is paradoxical TB iris and unmasking TB iris. The paradoxical TB iris is patient with TB and ATT before ART, new TB symptoms after ART initiation. The condition worsens. Unmasking TB iris, TB patient not on ATT, when they start ART, have an unusually inflammatory presentation of TB in the first 3 months of ART. So clinical manifestation, recurrent fevers, worsening of pulmonary infiltrates, enlarging pleural effusions. They may come with dyspnea, development of tuberculosis meningitis, enlarging tuberculomas or tuberculosis lesions elsewhere in the body. Pathogenesis, release of new antigen target during mycobacterial killing. Hypersensitivity such as antigens and exaggerated immune response. Various risk factors. So corticosteroids indications, raised ICP, complicated meningitis with hydrocephalus, vasculitis, arachnoiditis, very high CSF protein. The dexamethasone should be given 8 to 12 milligrams and tapered over 1 to 2 months. Role of corticosteroids is rational, restore the damaged area of vascular permeability, decrease the CSF production, decrease free radical production, inhibit cytokines, various cytokines and various chemokines. And Cochrane systemic review says the relative risk of reduction of death 0.78% and relative risk of reduction of residual neurological deficit 0.82. So tuberculoma without meningitis with spinal cord tuberculosis, helpful in symptoms, not controlled, worsening of ATT and acute spinal cord compression. So these various drugs and doses which we need not discuss. In case of they have reactions, vasculitis, seizures. So supportive treatment. This is specific treatment. Specific treatment is ATT and steroids. Always you give supportive treatment, good nutrition, reduction of cerebral edema, control of seizures. Now we control seizures. The better drug is levetiracetam. Shunt surgery for hydrocephalus is there. When you see patient is worsening, patient is TBM on treatment worsening, you have taken CT scan shows hydrocephalus, immediately refer to neurosurgeon for shunt surgery. And physiotherapy, very, very important is patient had focal left shade, semi-paresis, quadriparesis, or paraparesis due to spine, part spine. Always you have to submit for a physiotherapist. So indication of surgical intervention, hydrocephalus, tuberculosis cerebral abscess, vertebral tuberculosis with paraparesis. Finally, the worst prognosis factor for tuberculosis meningitis. What are the worst prognosis factors? Most important is stage 3. Stage 1 is non-specific, stage 2 minor deficits and major involvement, stage 3 major deficits like hemiparesis or multiple canal palsies, disadvantageity, decorticaticity. Stage 3 mortality is more than 50%. 50 to 70% will lose the patients. So the worst prognosis factor is stage. That's why you have to write the stage 3. You tell the prognosis in a better way. Other things are extremes of phase. Both infants and old people, the condition may worsen and may lose the patient. Malnutrition, presence of meningitis disease. In chest X-ray, If you see miliary TB, again worse prognosis. Hydrocephalus, a focal neurological deficit, low CSF glucose, again a worse prognostic factor, and markedly elevated CSF protein. These are the poor prognostic factors of tuberculosis meningitis. Thank you very much for your patient listening. Thank you.